Assalamu alaikum viewers. Today we are discussing a case here who is a diabetic lady on oral hypoglycemics, hypertensive as well as asthmatic. She was overweight with a BMI of 42.5. She had a right-sided renal tumor 6.5 centimeter or so in the lower pole, which is extending towards the hilum into the parenchyma. So it was deemed not suitable for nephronsparingsurgery, which is localized. So here you can see the tumor, which is arising from the lower pole, but it is moving towards the hilum, and hence the partial nephrectomy will not be advisable here. So we decided here to go for a radical nephrectomy in her, but her weight is so much that it is difficult to perform a nephrectomy, so we decided to go for a laparoscopic nephrectomy. So here is the case now. You can see the abdomen. The trick is here that put the patient on the edge of the table so that abdomen drops down, and it is important to mention here that an insulation must be put between the patient's abdomen and the metal of the table, otherwise a diathermy can have serious consequences. Huge. We have done this marking. Can you show this? So this is the tip of the 9th rib. This is the 8th rib, and then this is the costal margin here. This is the iliac crust here, anterior superior iliac spine. So arbitrarily we have made a triangle here. This will be our port. We have put it 2 finger beds below the 8th or the 9th rib because we can see in the CT that the liver is also huge and it may come into our way. So this is 2 finger bed below the 9th rib, and this is for the optical port, and then this is 7 centimeter, the working port, and then this is again 7 centimeter from the optical port, and between the two working ports the distance is 10 centimeter. So this makes this kind of triangle. But in the meanwhile, we have decided that we will put in a 5 millimeter port here in advance, so that this will be used for assistant as well as for the suction, and later on if the procedure is successfully completed, we will use this site for the drain placement. But before putting in the main ports like the visual port and the working ports, as you all know that ergonomics are extremely important in laparoscopy. A few centimeters of change of the port will make the ergonomics extremely difficult, and the procedure may become even impossible in such huge abdomen. So we have decided to put in the port here and then insert the ports under vision, and decide the ports under vision instead of arbitrarily drawing the lines. So this is the of course the vision is of 5 millimeter is not as good as it would be in 10 millimeter. You can see the edge of the liver here. The kidney along with its tumor can be seen. This is the gut, and now we will see our decided port sites. So the optical port is here. I think it is fair enough. However, if it comes a little more lower, it will be more ergonomically better, because I am using a 30-degree telescope, and the working port then will be here, and we will see is it possible. Yes, and another port is here. So we will also put another port for liver retraction, which would come here. So I think it was a nice decision, a good decision to put in a 5 millimeter port, and after putting this visual port, then decide about the port placement. And it has changed our decision a little bit. So we have to come a little lower, maybe 2 centimeter in the visual port, 2 centimeter here, 2 centimeter here, and also the port for the liver retraction. So okay, this is the final port placement. Now you can see that this is making a perfect triangle here. Again, the 10 centimeter, this is 7 centimeter, this is 7. So the manipulation angle automatically becomes 60 degree. And there is another triangle here, which is here. So this was the port which helped us deciding the actual port placement. Now if you can see, we have come 2 to 3 centimeter below the our measured or expected port placement. So this was a nice decision and a good decision by one of my assistants, Dr. Idris, and also Dr. Saad. Okay, so from the CT one can see that the liver is also quite huge and very heavy, and it is covering all the upper pole of the kidney. It will not be easy to lift it because of the weight. So we have started here before putting or placing the port for the liver retraction. We have started mobilizing the colon. So the colon is slowly and gradually mobilized from the lower pole. After we dissect this peritoneum to mobilize the colon from the kidney, we will have an idea how much do we have to retract the liver. Here you can see it's a huge liver having adhesions with the gyrotous fascia as well. So before lifting up the liver, we have to mobilize all the attachments of the liver around so that it can be lifted easily. So this peritoneum is being mobilized from the edge of the liver where it is attached. You can see the falciform ligament. It is also of a huge size, coming anteriorly towards the inferior border of the liver. So by the end we have to mobilize this falciform ligament as well. So you can imagine the weight of the liver here. Now mobilizing and cutting the triangular ligament here. It will give us a little more edge. Let's see how it goes. A very heavy liver with a round border is difficult to lift. So we have to cut a little bit more of the triangular ligament, because if we put in the liver retractor here in this condition, it will not be able to hold the liver, so we have to mobilize a little further. So the port for the liver retraction, a little bit of bleeding from the port side, but it's not significant. Now placing as you can see that the edge of the bladder of the liver is quite rounded, and it slips through the instruments. In advance we have placed a small gauze piece because it's a fatty abdomen, and there are a lot of small vessels in the fat, and which will make the field red. So in order to counter that redness and identify the structures, as in the red field usually it's difficult to identify the structures, identify the anatomy. So a gauze piece, a small one though, is at times helpful, although I don't routinely put in the gauze inside the abdomen, because there's a chance that it may get the color of the blood and become red, and at times it is difficult to differentiate it from other tissues, so there is a chance that it may get lost in the abdomen. So whenever I put in a gauze piece inside, I am always very cautious about where it is placed, what is the color. I ask my assistants to always remind me of the gauze. So here you can see that the renal vein and IVC are getting exposed. The duodenum is getting cauterized. Use the energy source away from the duodenum to avoid any thermal injuries, because a small bit of thermal injury, especially to the duodenum, can be a devastating. So recognizing those injuries is very difficult, and they are recognized late in the post-operative period, and by the time you recognize a duodenal injury, it has already caused extremely serious problems. So the gonadal vein is exposed, as I already mentioned, that there are small vessels in the fat, so those vessels, they get ruptured and they bleed, and they make the field red. So the field for me is already quite red. There are some more small kind of bleeding. However, the procedure continues. The important thing here is that one must be dissecting lateral to the gonadal vein, especially on the right side, because on the right side the gonadal vein is draining directly into the IVC. So any pressure during pushing and pulling of the lower pole of the kidney may lead to avulsion of this gonadal vein from the IVC, and that can also lead to some serious consequences. You can see we have made a window here. The ureter is also visible lateral to the gonadal vein, and it is crossing posteriorly the gonadal vein towards the pelvic brim in a different plane. So identifying all those things are extremely important. Now we can lift up the kidney without the danger of injuring or avulsing the gonadal vein. So here you can see a small vein is also crossing the ureter and is draining into the gonadal vein. So I decided to ligate this vein. Although the ligashore can seal a vessel, especially vein of this size, but it's always better to clip and then use a sealing device, a ligashore. So another window has been created above and below the vein. Now we will dissect this vein off the ureter. In the meanwhile, we are using a 30-degree telescope. So it is always important to remind the cameraman to make the field zero. So this is cut now nicely, and we can lift the lower pole of the kidney and then follow the gonadal vein, not following the lower pole of the kidney because the tumor is in the lower pole, and in the process there may be spillage of the tumor if it is breached. So it is always good to follow the gonadal vein in this condition, and after dissection of a little bit of portion, we are able to see the IVC very clearly. So I'm reminding my cameraman assistant to make the field zero. So zero field in a 30-degree telescope would mean that the psoas muscle and the IVC, they must be running horizontally across the screen rather than making an angle or running vertically. Dissecting the tissue away from the IVC will also relieve the pressure on the IVC, the pressure of the pulling. Where one can speed up the procedure, one should speed up, but where there is danger and there are dangerous curves on the road, one has to apply brakes and reduce the speed. So same is the principle here. When things are very clear, you can speed up a bit, but when things are hazy, you need to slow down. And in laparoscopy, they say that if you reduce your speed, actually you will be increasing your speed, because if you do things slowly, things will be quite clean, tidy, so the procedure will end up quickly as compared to if you are trying and running, trying to catch speeds, then something inadvertent may happen and the procedure will be prolonged. So slowness is the essence of laparoscopy. So dissecting the renal vein above and below will give you an idea about the size of the vein. We have a little issue with our leverage because for good laparoscopy, having good ergonomics, one must have half the instrument inside the abdomen and half outside. However, patient with such a huge BMI and a big abdomen, that leverage cannot be perfect. So that's why the movements of my instruments will be a little different than in patients where the leverage of the instruments is good. In this case, we are extremely lucky to find the renal artery in the usual location, and that too quite away from the renal vein, so we can dissect it easily. We will dissect the lymphatic tissue around the artery to gain some length. This will make the clipping of this artery easy. So we will take a chance here and take an advantage here just to apply one clip so that supply to the kidney is reduced. So the next thing is to go for the dissection of the renal vein with the beautiful instrument, a 10 millimeter right angle, and then check whether the vein is distending or not. So it is not distending, it means it has a single artery. Another advantage of following the IVC during the dissection is that you will be able to find the main stem of the artery. If you are going away and dissecting away from the IVC, then there are chances that the artery may be dividing into branches, and one must be encountering branches, clip one branch and the other one will be left. So the second clip is being applied, the first clip is making hindrance, so we just pull it down and we cut this vein. I cannot see the other end of the vein, so the angle of 30-degree telescope is now changed. Now you can see how beautifully it can show us the other side of the vein. Now completing the dissection of the lower pole, and we have to be careful zeroing the angle. As you saw, now the IVC is perfectly horizontal on the screen, so the perception that the brain gets is actually real now. Slowly and gradually we are dissecting this tissue away and cleaning the psoas muscle. It's encouraging. So we are getting bolder and bolder. At the start of the procedure, we were a little worried about the size of the abdomen, the size of the liver. So here we can encounter some retrograde bleed. However, it is not important and one must not be worried. Increasing the abdominal pressure from 12 to 14 can have significant effect on this bleeding, and it can be stopped by increasing just the abdominal pressure because it is just retrograde bleed. Now we cut the artery. The field is quite clean now. A little bit of irrigation and then suction can make the field clean. As you see, we still have that gauze piece inside. Suction over the gauze piece can be very helpful. So trying now to mobilize, although the movements of our instruments, you can judge that they are not as smooth as they would be, and the reason for that I already explained is that almost the instruments are almost totally inside the abdomen. Even the trocars are inside the abdomen up till their necks. That's why the movements are not very good. For such kind of patients, one should have instruments which are 45 centimeter in length. Here we have 36 centimeter instruments. However, we are lucky to have such instruments here. You can see the edge of the adrenal. So as the tumor is located in the lower pole, we can spare the adrenal, and so that's why we are following the upper pole of the kidney rather than the psoas. If we were to remove the adrenal along with the kidney, then we must have followed the psoas muscle rather than the upper pole of the kidney. Small vessels have interchange with the upper pole of the kidney, the Ureter of the upper pole, and between the adrenal, and then can be cumbersome at times. So dissection in horizontal plane along the upper pole, between the upper pole of the kidney and the edge of the adrenal, is recommended. If you go deeper and dig deeper into the fat between the adrenal gland and the upper pole of the kidney, there are highly likely chances of opening up those small vessels, and they can bleed and make the field dirty again. That will hamper the vision, will absorb most of the light, so things will become harder. Mobilizing the lateral surface or the lateral aspect of the kidney become easier if the lower surface of the kidney is cleared from the psoas muscle beforehand, making the angle 0 again. There are some tissues between the kidney, the lateral abdominal wall and the Ureter. So they are taken. It's mostly avascular tissue. However, they do have strong attachments. So now completing the ureter, the lateral aspect of the kidney, taking as much length of the ureter as possible. And then clipping this ureter proximally and distally, and then cutting in between. A little bit of suction and irrigation will be done at the end of the procedure to make the cavity clean, and the pressure will be dropped to 6 from 12, so that if there are any small bleeders hiding behind the high pressure, they will pop up and we'll be able to coagulate them with monopolar, bipolar, or with the ligashore. So the procedure is now almost complete. So the procedure is now completed. We had a little problem with the length of our instrument because this is too far away from the target now, and it was difficult to go to the vein and clip it. However, you can see here that this is the artery, this is the vein, and this is the cavity. We have washed it. We have not yet removed the specimen. Okay, so this is the specimen. We will remove it through this camera port, a little extension, 5 centimeter or 6 centimeter maybe, and we will put in a drain here. Thank you.